Hello, everyone, and welcome to this session of the AI Nurses Network webinar series. Today, we have a fantastic colleague, Dr. Robin Austin, with us, who's an associate professor at the School of Nursing at the University of Minnesota. So, over to you, Robin.
Great. Thank you so much for having me. And I'm super excited to be here and a part of this network. So my presentation today is called Empowering Progress, Advancing Midlife Women's Health in the Age of AI Data-Driven Healthcare. Kind of a mouthful, but I'll share more about what that really means as we kind of get into it. So I'm just going to jump right in. Just a quick brief about me. Again, I'm at the University of Minnesota School of Nursing, and I'm also the director for our Center for Nursing Informatics. I also do have a faculty position at the Earl E. Bakken Faculty Center for Spirituality and Healing as graduate faculty. And also what kind of spurred a lot of this work is not only personally around midlife women's health, but also I joined the Menopause Society, and I was applied for and received a 2-year research mentorship program through the Menopause Society. So it's been really great to connect with other women, specifically in doing research in this space, clinical researchers, but also with other researchers as well, but really specifically around women's health and menopause and perimenopause. So, and some of my work has shifted in kind of looking at I would say lack of data in women's health in this specific area around midlife. So here's our just a brief objectives really quick is analyzing data trends in women's health and focusing on menopause specifically, identifying gaps and opportunities for improvement, describe current research focusing on to improve menopause data management, but also opportunities for AI. And that's really where this work comes in. And so I see my work a lot around how does this work really lay the groundwork or the foundation to have better data for women's health AI tools in the future. So the big thing that there were 2 reports that came out, and one was called Closing the Women's Health Gap. And this really looks at specifically, there's a huge gap in data regarding women's health, specifically around midlife women. And that typically is around menopause, but also the related data around menopause as well. Just a little bit of background is that menopause is a universal experience, over 51% of the world's population. Also that women drive global economy, which is part of this vital capacity to really be able to have better data to support women as we are major economic providers within the global health workforce. And there's estimations by 2030 that 1.2 billion women worldwide will be in menopause or postmenopausal phase, and 47 more million entering that each year as well. So that's a huge impact, this phase of life on healthcare, but also just everyday quality of life for women as well, and their ability to manage life, workforce development, all of those components. And so really focusing on menopause specific data and policy is really pivotal because it's been underserved, under-researched for a very, very long time. And I'll kind of get into a little bit more of that as well, but really needing to tackle this huge, there's significant unmet needs that we could help to alleviate health burdens. So why menopause and why now? It feels like in the media you see a lot of, you can't open it up almost without any news outlet without talking about perimenopause and menopause. And that Women's Health Initiative in 2002 was a large study that was happening. And unfortunately, there was some data that we're just saying it's misinterpreted at that time, leaving women to really be quite frightful of hormone therapy at that time. And now since then, we've been going back and, as I say, we just other researchers to really re-identify some of that data and reinterpret and reanalyze, only to discover that there were some significant gaps in that research to begin with. And now really getting better data to understand the benefits potentially around hormone therapy, really what we need to be sharing with women around menopause, and getting much better data, because it feels like once that study, the Women's Health Initiative study came out, it felt like there was a lot of research that just somewhat halted. There are some longitudinal studies that continue to go on, but really there's just a gap, I would say, in women's health, specifically around midlife. We have new understanding now and the growing awareness of long-term effects of menopause on pretty much every system you can think of in your body: cardiovascular, brain health, musculoskeletal syndrome, bone health, osteoporosis, metabolic health, and the list goes on and on. But really finding out that we need much better data in the long run for women specifically to really set them up better for healthy aging and to increase that lifespan. So what is menopause? Just a kind of a broad definition is that perimenopause or menopause transition is the irregular menstrual cycle that can happen with or without symptoms. And sometimes it can begin in our mid 40s before we even think around quote unquote menopause. And I'll get into that definition in a second. But it's really can be lasting anywhere 8 to 10 years. And so there's a lot of time where women maybe not feeling themselves or going through some transitions that can now have some assistance potentially to alleviate the symptoms that can come with menopause. And then the diagnosis, or what they call menopause, is a permanent cessation of menses due to loss of ovarian function or surgical, could be as well, but it has to be consecutive of 12 months of amenorrhea. The average age is 51.2. And additionally, menopause is defined as secondary. You could have a surgical or medical intervention as well to be additionally defined. But it's really that they kind of as a guide, that 12 months of menses or absence of menses, really then you post kind of diagnose or have the termination of what they call menopause. So symptoms, as I said, vary significantly, and it just depends on the female. Everybody is very, very different, independent, or individualized. Personalized medicine is really a huge approach, I think, coming to menopause symptoms, because 75% of women experience vasomotor symptoms, or also what's called hot flashes and potentially night sweats. They say 80% of women disrupts daily life. And then a third experience depression, also anxiety. And we're also understanding that ADHD in adult women is a little bit more being diagnosed or recognized now throughout this transition as well. There's significantly racial and ethnic differences around menopause symptoms. But however, hormone therapy prescribing rates are as low to 4 to 6% for women from the last studies that I've seen. And so there's really I would say a gap in knowledge and education for women, what is available and what is safe to be taking around menopause. Oops, yeah, sorry. So there's really a huge health data gap, and it's also causing a huge economic impact. And so I looked at this from a standpoint, again, of nursing as well. And so we have 4.7 million nurses nationwide in the US. That's much larger, around 9 million on a global economy or global scale. And the average age of the working nurses at around 47. So that is a prime age for being perimenopause, menopause. And the data around economic impact of that is that they're showing the data is that 1 in 5 women may leave their jobs due to menopause related work. And that's a significant, I can think of the global impact on that, the economic impact on the 1 in 5 women leaving their jobs. That's a huge component. The other thing I wanted to bring up specifically for our profession in nursing, that we do a lot of shift work. And so shift work, as we know, the research has shown there's potential disruption of circadian rhythms, altering that sleep-wake cycle, which also does impact hormones, the estrogen progesterone patterns, linking it to irregular menses. And so they're thinking potentially that night shift work or other shift work, maybe earlier onset of menopause potentially. And so they're trying to figure out more of that. And I just bring it up to bring attention, as this is around our nursing workforce as well. And also some other stats around loss of work productivity. They're estimating it around 1.8 billion annually. And then medical costs of direct or indirect care is around 26 billion, potentially as well. So huge economic impact. And I think of that from the data perspective. And I'll get to that in just a second. It's another conundrum that we find ourselves in, specifically around midlife women's health. So I did a little bit of work too, kind of diving into when I first started looking at menopause research in general and how little there really was. And so I did a search using PubMed, and I used just the term menopause just to find full text articles. You can see there's around over 6,500. And then for the same search time frame, and then I use the word diabetes in full text articles, and you can see there's over 78,000. And so there's just a significant difference in the amount of research, just articles that were published between that time. So it leads us to having a gap in research, trying to find better ways to manage this for women, what is safe, trying to get better information out there to not only patients and individuals, but also healthcare providers as well, to be able to recommend some newer approaches. And so it's the other staggering statistics is that women live longer than men. They may spend about a third, if not longer, in post-menopause throughout their life. But women also spend an average around 9 years in poorer health than men as well. And so there's really highly significance on disease and high mortality. And some conditions such as mental health and or menopause, which lead to disability, are often overlooked, just to bring that to the forefront as well. So root causes of some of these gaps is definitely the science. As we know, research has defaulted to the male body, and it hinders what we understand about sex-based biological differences, resulting in fewer or less effective treatments. I think that has been being brought out way more in awareness as of late as well. So there's one researcher that I follow, and I think she's an exercise physiologist by background, and she was just pointing out that women are not small men. We have very different biology, and so to really be able to focus on filling that gap with women in research. Also, there's just gaps in data. One of the big highlights that I took away from the Menopause Society conference I went to, not this year, but the 2 years ago as well, is that menopause is a major data problem. And so from an informatics perspective, I think of that as it's quite worrisome as we try to develop newer approaches, either digital health, trying to get better data, and or AI tools needs quality data to be built on. And so that for me was a big concern or red flag, is that we don't have quality data to build some of these tools in the future. And I'll share more about that in a second. And the last is potentially care delivery. And that women face more barriers in care, potentially diagnostic delays, and then resulting in suboptimal treatments. So the other thing I'd like to bring up as well around certainly menopause itself and now being much more in the media and then kind of in the limelight is that there's also potential for misinformation, and that also can impact data. And so healthcare providers are a primary source of information, and that 66% of women that were surveyed on a study that was around preventative health said that social media is also seen as a valuable resource. And so, which is good and bad, meaning that there's information that's out there, but what is accurate and what is reliable. And so making sure that we get accurate health information in the hands of healthcare providers to be able to build and have better evidenced quality care built on, and then to therefore generate that into data on the back end as well. And then one statistic that I have underlined here was a little bit concerning around misinformation, specifically just in general, is that 24% of women that were under the age of 50 said that health influencers are just as reliable as healthcare providers, which was a little bit concerning, but I take that with a grain of salt. But at the same time, the awareness of misinformation that's floating out there has a tremendous impact on care as well. So what kind of sparked me kind of getting into more of this research is that a couple of years ago, the former administration in the US put an executive order out on advancing women's health research and innovation. And it was an executive order from the Biden administration, and they really had an impact specifically in Section 5 of this executive order called Galvanizing Research on Women's Midlife Health. And in that order, they also called for the idea of new common data elements. And that goes to the idea that we need better quality data, specifically around midlife women's health. And so for me, having an informatics background and data science really took that as that is something I can work on with my colleagues or myself to really understand what is the crux of what we need around midlife women's health, specifically in the era of AI generated tools, algorithms, and things like that. We need better data. And this is one way, I think, to do that. And so fast forward to where we are today, specifically in the US, there is a new appropriations bill that went through in 2026, or going forward in 2026. And I was kind of a nerd, and I scoured the appropriations bill, and I did find that there were still a call out for common data elements for women's health. So I'm taking that as my approach to continuing this work to go forward, because it is so quite needed. And I'm really, really passionate about making sure women, specifically in midlife, have the quality data that they have to really set us up for healthy aging and independence in the future. So I'm going to share a couple studies. I'm going to share a couple studies that I was working on, specifically looking at just trying to get my arms around where the data is and how do we start to identify specifically signs and symptoms of menopause. How are we documenting that within the electronic health record, trying to really improve our infrastructure around data that we currently have around electronic health records. And so this specific study was looking at, we have menopause symptom checklists that are validated checklists to have women fill out or providers fill out around, do these symptoms apply to you? looking at a standardized way to collect this data on the upfront so we can then have better data, I think, on the back end as well. So I wanted to find out what are the commonalities of these checklists? How are they standardized data? Where do they fall within that realm within informatics lens? So we took about 6 menopause checklist surveys that were validated tools that I found from the literature, and then I mapped those to what's called the Omaha system, which is a standardized terminology within the infrastructure around standardized terminology. And so we mapped it to this the Omaha system also as a framework because it really provides a holistic viewpoint. If you're familiar with the Omaha system, it has 4 domains of health, which is the environmental domain, psychosocial domain, physiological, and then health-related behaviors as well. And so I use that as kind of a framework to really understand, again, what are all the factors that impact or the symptoms that impact women with menopause signs and symptoms. So we then map these standardized checklists to an Omaha system problem, a sign and symptom, and then the corresponding SNOMED CT code as well to make sure that these could be potentially standardized across multiple systems, really looking for an interoperability perspective. So here's what we did, the checklist. There were 6 in total. So we had 239 items overall across all the checklists. We had 2 reviewers that were mapping these to the Omaha system. Differences were resolved by consensus, and we looked at it from a full or a partial match within the Omaha system as well. So these results are in if you think the QR code is working, it's called an article is towards solving the menopause data gap if you're interested in that. But the items from the toolkits or the tools that we used range from 11 to 122. All of these were mapped to the Omaha system. We found that 72 signs and symptoms for 21 problems across when we deduplicated what was there, that was the total what we found. And so of the 72, there were 70 that full match to the problem level within the Omaha system, and which is about 97%. And then there were 67 or 93% that were a full or partial match to the sign and symptom level of the Omaha system. And so while there's a lot of coverage, there wasn't exact coverage. And so that leads us to be able to figure out in the future, how do we then get things embedded within other standardized terminology and what was not present within that. And so here are some of the signs and symptoms that were not mapped. For example, in the skin problem in the Omaha system, there were some signs and symptoms related to increased facial hair, thinning of hair, or changes in tone and texture of the skin were not captured within the Omaha system. And so therefore that potential work going forward. And the other issue that we came across is that, so for example, for the sweating or night sweats or hot flashes, for example, really more or less sweating and night sweats, we're not, the pallor and perspiration is under the pain problem within the Omaha system, but that is not necessarily indicative of why that sign or symptom is happening for women related to menopause signs and symptoms. And so it was a little bit of a mismatch for this. It wasn't a pain problem per se. And so that also needs to be addressed going forward as well. So really this provides us a foundation for understanding assessments of standardized menopause signs and symptoms. It's a first step to really looking at how do we standardize some of these checklists across clinical systems to really be able to have something that might be standardized. And one thing that was lacking was the environmental domain in some of these symptom checklists. Which isn't too surprising. However, it does raise a red flag because there's emerging research linking environmental toxins, such as the microplastics that we have in our environment, to potentially early menopause. And so more research is needed, but also links to the fact that maybe we should be inquiring about some of this with women when we talk about them at their clinical intakes around environmental exposures. More research is coming. And then this next study that we did is looking at a potential standardized guideline. And so this work is currently just submitted for publication, but we were trying to map or harmonize data across. We found 2 high quality clinical guidelines. And we then mapped those again to the Omaha system around the Omaha system problem and intervention and also a target. And this is again for us to find a way to hopefully map across systems to try to provide interoperability data around clinical guidelines for what people are maybe recognizing and suggesting within clinical practice in a standardized way, and also a way to document that as well. So this work is just recently completed, and our preliminary results showed that we had 69 unique interventions across these two unique menopause guidelines, 12 problems, and then 17 targets. Most of the 12 problems were from the physiological domain, which isn't surprising because it's menopause. But we did have two that were health-related behaviors and psychosocial domains as well. The most common problem was around reproduction, circulation, mental health, and then neuromuscular function as well. And then case management was the most frequent intervention recognized within these guidelines, which again isn't too surprising when we think about how menopause is currently managed in a clinical setting. But really trying to standardize my approach is really, let's get some standardized ways to recommend care approaches or interventions for women that we can then translate that into better documentation and better real world clinical data for which we can then build future models off of. And this is just a quick snapshot. I was playing with what's called the Sankey diagram, just because it's a great, cool visual to understand how things all fit together. So on the left-hand side of the screen, we have the Omaha system problem, which you can see reproduction function is the biggest chunk of where those problems are located for this guideline. And then in the middle is our category, which means the intervention itself, case management, surveillance, treatments, guidance, and counseling, and our treatments and procedures as well. Kind of in the middle. So what is the care problem? What is the intervention that's being suggested or recognized? And then on the far side is a target, which is more of an individualized approach for that intervention as well. So you can see, I always say it was trying to find a pattern in all of these, but I guess the pattern is that there's no pattern because care is very individualized within menopause care, and it's certainly across several domains and several problems in and of itself that it impacts for women. So it's just a good visual to, again, be able to represent menopause itself and the complexity of the data that we have going forward with the specific condition. And the last paper I'll share, their study that we did was really trying to identify and understand how is menopause being documented in the electronic health record. So we thought, let's look at research and studies that say that they used data or they used electronic health record data for a menopause study. And this is kind of our methods that we use looking at these databases. Here's some of our key terms, but this is not an exhaustive list. But it was just our approach to identify what were the specific data elements that they used from the electronic health record to do some of this research, to give us some insight into how is this even being documented. So across all these studies, we came up with 3 themes, and there's a full paper hopefully coming out across our fingers. That documentation is limited, and so there's an absence of standardized terminology, which isn't surprising, and then lack of structured fields within the EHR, which leads to incomplete data capture around menopause-related data, hindering care delivery and research. Which isn't too surprising. Some of the studies really called out that there was not a field for me to document some of these things. There was no space for me to, unless in the clinical note, to identify maybe when a final menstrual period date was, or even some of the signs and symptoms ended up being in a clinical note, which we all know can be a little bit harder to gather that data from, to be able to do some additional analyses and or AI methodologies and machine learning methods. So there's also the other theme was that it was under treatment of menopause was called out as well. So this reflects that there's limited clinical interventions that were being offered. And going back to one of the first few slides is that there's a large percentage of women that are having hot flashes, sleep disturbances, other signs and symptoms that impact quality of life. However, only 4 to 6% were actually being or were on a hormone replacement therapy as well. So hopefully some of the messaging will start to shift around the safe and effectiveness of some of these practices as well. The last point is that there's also underreporting of menopause symptoms, which may be that there's a lack of consistent, maybe patient-reported data. Maybe patients are maybe not reporting because they're feeling stigma or embarrassed or what have you. Or also in the papers were suggesting that sometimes it's just not asked. It's not screened in a structural way or a standardized way, which we kind of saw from the very first work we were doing around standardized checklists. So those are not too surprising, but certainly reveals some significant gaps that we could be doing in clinical practice around just documenting these signs and symptoms to get better quality data. So this leads to future directions in research, is that realize that there's a lack of our limited standardized data, which hinders poor interoperability and really constrains being able to then have a broader scope of midlife women's research and care. It's certainly happening in silos, but we're not able to share that data interoperability wise. And so really my big kind of mission, I think, going forward, probably for about the rest of my career, is really developing some common data elements around menopause, and really kind of having some progress using some SNOMED CT, loin codes, ICD-10 codes, things like that, to really then make it not only interoperable, but across on a global scale as well. So we can really start to look at trends globally for women as well in the international health space as well. This work is then also very foundational to really build upon quality data and implementation of real world clinical settings. I think that what we waiting for RCTs may or may not, it's a great to have a randomized control trials, yes, but also can we use real world clinical data to help speed up some of these gaps that we are seeing in women's health that are certainly impacting quality of life. And so that then moving forward really is having some of those real world clinical data to really get AI ready data sets. That's kind of another way to approach from common data elements, standardized quality data, being able to then to produce AI ready data sets across health institutions to really be able to use some of our methodologies that we now have available. But we need high quality data to be able to do that, to have impact on our meaningful insights that we then can gather from that data. And I keep my mantra is that AI is only good as the data that it's trained on, and specifically there, with a gap as we have in women's health, specifically midlife women's health, there's lots of work to do infrastructure wise. So hopefully this was insightful, just a quick snapshot, and I thank you for your attention. And also feel free to connect with me through LinkedIn, and here's my email address as well. And so we'll stop and take some questions.
Oh, that's great, Robin. Thanks so much for the presentation because I'm heading in that age direction myself, so it's good to get more insights into what to expect.
Great.
And yeah,
Yes.
and there's lots of nurses, as you said, in that age bracket who will really, what you're talking about will really resonate with them. And I'm sure every other country has data problems around women's health, especially midlife, which is very neglected, I think. Um,
Yes.
so I'd really love to know, yeah, how you got into this area of research in terms of nursing informatics.
Yeah, great. Thank you. So, just personally myself, I was just starting to experience some midlife health changes. And then, of course, as in research, I started to kind of diving into the literature, and I realized that where is the date? Like, where is the studies? Like, what is happening? And it was really just from a personal motivational standpoint. I thought this is ridiculous. We're today's day and age. It was in 2024 at the time. It's like, this is crazy. Like, why do we not have better data? And so the more looking into it, that's why I joined the Menopause Society. Being informatics background, that was just kind of a leap because it's very clinical focused. It was not my area of specialty. But I thought, well, if I'm going to figure out what's happening in the space research wise, I want to go right to that specific society. There's also an International Menopause Society as well that does a lot of great work too. Wanted to make sure I pointed that out, but that was just a personal interest and kind of a driving. And then I just met so many great researchers through some of these networks. And I felt like I was almost cold emailing people that I would read their article and I said, I see you're doing this research. This is who I am. I'm looking at it from this data perspective. And people were very willing to share their knowledge and share their resources and said, oh, you need to connect with so and so, and you need to connect with so and so. And so I think it was more out of personal frustration that I decided to get into it, and then realize what a gap there is. And I thought, well, especially around the data part, I thought, well, I can do that. That is my niche, that is my area, and I can hopefully make a big impact with my skill set in informatics and apply it to this specific area.
Super. Yeah. So, do you have any advice, I guess, maybe for other nurses who want to understand maybe sort of data standards and how to go about researching that area?
Yeah, absolutely. And so I would say that just start looking if there's a condition that you're interested in. I always have just like, what are some of the common data elements? Is there anything in the standardized terminology, whether you're looking at a SNOMED or a LOINC kind of a terminology, or I'm very familiar with some of our nursing terminologies that we have. And so I picked the Omaha system. That's what I'm very familiar with. But there's also NANDA, NIC, and NOC. There's others that you could approach as well. I think just to help kind of just start to dabble in this space and say, what does it look like if I were to take this data and try to standardize it? Or maybe some are already created, and can you build off of what is already done in the literature? The Omaha system has been used in very many settings, but looking at it from this specific condition or women's health component or time frame, there wasn't a lot out there. So I thought, well, that's another kind of area I can influence potentially as well. So I think it's just kind of finding out what's of interest, and then just start kind of figuring out what's in the literature, and also kind of to pinpoint who else was doing some of that work in that space or in that specific standardized terminology would be another way to get into it too.
Great, great. And yeah, my last question is a little bit trickier, but if we had all of loads of great data about women's health midlife, what kind of AI tools do you think women would really benefit from?
Yeah, great question. So this is kind of piggybacking off of, I just did a kind of a research survey questionnaire, and I was analyzing the data over the holiday break. But it was really asking women their preferences around
Mm,
data and what symptoms would they track, or do they want to track perimenopause or menopause symptoms. And a lot of them wanted to track their sleep, hot flashes, daily kind of brain fog, mental health, exercise, things like that. But it was really that they also wanted some personalized, individualized recommendations. And so maybe using AI to really pinpoint or try to cluster signs and symptoms for women, and then be able to make recommendations off those clusters. I feel like sometimes maybe you're having some one or two signs and symptoms here and there, but it doesn't make sense where they're coming from. But trying to find patterns, I think, are going to be a critical component for women's experiencing kind of this midlife transition. And so I can really see AI having a huge influence on being able to identify these patterns on a deeper level, but also some of the clustering components that we haven't really been able to put together because we haven't had the quality data or larger data sets to do so. I think, and then being able to look at that long-term or longitudinally as well. So can we start to see some clustering differences or impacts on health outcomes by being able to look at that? So I think of personalized interventions, pattern recognition to really influence outcomes in the long run.
sounds great. Well, hopefully, we'll head in that direction, and your work will
Yes,
contribute to some of the data sets. Lovely. Well, thanks so much for your time, Robin. It was great to hear about your work, and yeah, I hope please keep in touch about what you're doing.
I will. Thank you so much for the opportunity. I appreciate it.
You're welcome.